essentially how we have a limitation to the amount of certain substances that are reabsorbed. This is called the transport maximum. And so it's the rate at which all of our transporters have been saturated. And if we think back to this scenario here, this is a facilitated diffusion. This is requiring a carrier. And so it would be easy to think that you can just reabsorb ad libitum, like you can reabsorb into infinity, but the idea is that you cannot. When these transporters get saturated, you can no longer reabsorb things like glucose, which are requiring transporters. And so you start to see that being spilled into the urine. Okay, and that is why we see diabetics have glucose in their urine, because they have so much glucose in their plasma. It's being freely filtered, but it's being reabsorbed at a rate that completely saturates those carriers, and so they're no longer able to reabsorb any more of that glucose, and then it's spilled into the urine inappropriately. And so when a solute is transported across the epithelium by these protein transporters or carriers, saturation can occur. When that saturation occurs, we call that transport maximum, okay? We can also talk about renal threshold. So renal threshold is the plasma concentration at which we see that saturation occur. So the transport maximum is the rate of movement that causes that saturation. Renal threshold is the plasma concentration at which we begin to see that saturation. So for a solute that is normally 100% reabsorbed, like glucose, which is the main example, if a solute in the filtrate is saturating those carriers, then some of that solute will begin to be spilled or excreted in the urine. And so the solute concentration in the plasma, in other words, our glucose plasma concentration, at which we start seeing saturation of those carriers, is what we refer to as our renal threshold. So looking more specifically at glucose as our main example here, glucose should be freely filtered across the glomerulus, right? No impedance to that. It should be 100% reabsorbed across the proximal tubule via that mechanism that we just described. So secondary active transport across the apical surface, and then facilitated diffusion across the basolateral surface. And so in a normal healthy adult with normal healthy blood sugar levels, we should not see any glucose appear in the urine, okay? Let's talk about the renal handling of glucose. So essentially, if we were to calculate the filtered load of glucose, we know that the plasma concentration of glucose should be about 100 milligrams per deciliter, based upon what we described earlier. If we convert this to milliliters per milligrams per milliliter, excuse me, this will become 1 milligram per milliliter. So just to convert those units so that we can multiply to find our filtered load. So we multiply this 1 milligram per milliliter times our GFR, that gives us a filtered load of glucose of 125 milligrams per minute, okay? So that is our filtered load of glucose. We can also think about what our transport maximum would be for glucose. And theoretically, it should be 375 milligrams per minute. And I say theoretically because this is what physiologists describe. So a bunch of physiologists sitting in a lab, probably bored, took some Petri dishes. They took some of these cells from our proximal tubule, put them in the Petri dishes. They exposed them to as much glucose as possible. And they measured what was the rate of glucose transport that would occur before these carriers became saturated. And they came up with this theoretical value of 375 milligrams per minute, which is the transport maximum for glucose theoretically, okay? Now, based upon that value, we can substitute that for our equation here. So transport maximum is equal to our GFR multiplied by our renal threshold. And so if we take this theoretical value, excuse me, of 375, and we plug that into our equation here. So 375 on this end, excuse me. Okay, so 375 on this end for our transport maximum. We know what our GFR is, it's about 125 on this end. And so we can substitute these two values to find our theoretical renal threshold. So if we plug that 375 in and we plug that 125 in, we would get a renal threshold value of 300 milligrams per deciliter. Again, this is a theoretical renal threshold. This is what physiologists theorize this to be based upon their scientific in vitro experiments, okay? Now, if you were to look at this in vivo, so in actual human patients and actual human bodies, so this is what clinicians discover, so actual physicians or clinicians who took some patients who had high glucose levels, they actually measured that the renal threshold was significantly lower. So at 160 to 180 milligrams per deciliter, so at those plasma concentrations of glucose, they started seeing saturation of carriers and spillage of glucose into the urine. So all of this is to show you that there's a bit of a discrepancy between what physiologists describe as the theoretical renal threshold, right, that plasma concentration at which we see glucose spilling into the urine, versus the actual clinical or in vivo value of our renal threshold, which is about 160 to 180, which is where we physically start seeing patients spill glucose into the urine if they have these values in terms of their glucose plasma concentration. Okay, and so on that basis, if we were to calculate transport maximum based upon this actual or clinical renal threshold, it'll be closer to about 225 milligrams per minute. All right, so just to all of this just to show you that there's a bit of a discrepancy between what physiologists think and what clinicians think. And I'm not going to ask you to calculate any of this. I'm not going to ask you to reproduce any of these numbers. What I will ask you to take away from this is the difference between transport maximums. You should be able to define or describe transport maximum, and you should be able to define or describe the renal threshold, okay? And so just to summarize those ideas here, the transport maximum, we said, is the plasma concentration of a solute at which the carriers are fully saturated and the solute can no longer be fully reabsorbed, and we begin to see that solute spill into the urine, right? That is the plasma concentration at which we see saturation. The renal, I think I mixed it up. So the renal threshold is what I just described. The renal threshold is the plasma concentration at which we see the spillage of this solute. The transport maximum is the rate of transport. So if we look at this value here, this is milligram per minute. So this is a rate. It's the rate of transport of our solute across the membrane of our cell at which we see that exact same idea, at which we see saturation of the carriers, and we now start to see spillage of this solute into the urine. Okay, so the renal threshold is a plasma concentration of the solute at which we see spilling. The transport maximum is a rate of transport at which we see that spilling. Okay, so just to further illustrate that here, we've got this graph that's showing the rate of glucose movement on the Y here, the plasma concentration of our solute, which is glucose in this instance, on the X here. And so if we were to compare these two variables, we would see a completely linear curve in terms of filtration. So glucose is being fully filtered. That means if I increase my plasma concentration of glucose, I'm going to increase my rate of glucose movement according to filtration. And so that's going to happen in a directly linear fashion. If we think about the absorption now, this is how much of that can be reclaimed into the peritubular capillaries. And so this is going to be limited by the rate of transport of our carriers. And so if I increase glucose concentration, I'm going to see that at a certain point, my graph is going to start to level out or flatten off because I have completely saturated my carriers. This is called transport maximum. So the rate at which I can no longer move glucose across the membrane of my cell, that is about 380 milligrams per minute, right, theoretically. That is called my transport maximum. So that is a rate at which I see saturation. And we can compare that to the renal threshold, which is the plasma concentration at which I see that saturation. So again, thinking about that saturation at about 160 to 180, we start to see that saturation if the glucose concentration in our blood is at that level, and we're going to begin to see excretion of that solute, in other words, glucose spilling into the urine here. Okay. Let's talk about the other processes beyond reabsorption. So secretion is also happening across the tubular structures here. Secretion is moving across the exact same barriers or the exact same structures, our epithelial cell of the tubule, our peritubular space, our endothelial cell of the peritubular capillary, but the movement of direction is going to be in the opposite direction, okay? Some of the substances that are secreted are going to be potassium, hydrogen ions, and hydrogen ions are secreted as a way for us to balance the acidity of our plasma. So if we're in acidic states, we can lose some of that acid via the secretion of hydrogen ions. Whereas we saw in the reabsorption, bicarbonate was one of those things that was reabsorbed, and that is a way for us to adjust our acid base as well. Choline, creatinine, and penicillin are all things that can be secreted across the tubule. Many other medications, so other byproducts or metabolites of medications can be lost through the kidneys as well. This is why it's so important to be mindful of how you're taking some of these exogenous medications, because they can be really taxing to the kidneys when the kidneys have to secrete them in order to rid the body of some of those toxic metabolites. Okay, sometimes the liver is involved in that processing as well. All right, so in the final few minutes here, we're going to look at these checkpoint questions, and then we'll reconvene this on Monday. So the first question here is to describe the barriers for reabsorption and secretion. And then it goes on to say, be sure to include all plasma membranes that must be crossed by the substance being reabsorbed or secreted. So what are those barriers to secretion or reabsorption? All right, everyone's super quiet. I know it's Friday, we're probably all ready to go, ready to start the weekend already. Okay, all right, so I'm seeing some responses here, excellent. So the apical membrane of the tubule cell is one, excellent. Someone is saying the lumen, so the lumen is where we start, it's not necessarily a membrane that we're gonna cross. And then someone else is saying going from the lumen, across the apical surface of the epithelia, across the basement membrane, across the peritubular space, and then through the capillary endothelial cell into the blood. Excellent, so well said. So from the lumen, we go across the apical surface of our epithelial cell of the tubule. We go across the basement membrane of that tubule cell. We then go across the peritubular space, and then we go across the capillary endothelial layer of our peritubular capillary. So excellent, those are the membranes that we cross for reabsorption in one direction, but also for secretion in the opposite direction. Number two here, what is the general mechanism for water reabsorption? So how do we reabsorb water? Is it active? Is it passive? Does it require a carrier? How are we reabsorbing water across the tubule here? Osmosis, excellent. So osmosis is the mechanism by where someone is also saying passive, which is also synonymous there. So it's the mechanism by where we pump solute, so we create a solute gradient, and then water will move passively according to its osmotic gradient, right? So osmosis is one way to describe that. Passive movement of water is another way to describe that. Great. Okay. And then the third question here is to define the terms transport maximum and renal threshold. So we'll start with transport maximum. So what is the transport maximum versus the renal threshold? All right, so, okay, so someone is answering here. The transport maximum is the rate of transport at which spillage occurs into the urine. Excellent. So starting with the word weight, really crucial there. It's the rate of transport that's happening at which we see those carriers get saturated and we start seeing spillage of that solute into the urine. And then how would renal threshold differ? So how is renal threshold differing to transport maximum? Okay, we're actually out of time. So the renal threshold is the plasma concentration. Excellent. So someone else is responding here. The concentration of the solute at which that spillage occurs. So it's kind of the two sides of the same coin. One is the rate of movement at which we see that spillage. The other is the plasma concentration at which we see that spillage. Okay.